Okay, we are now recording. Sorry about that for everyone who's just joining the recording later in the day. We were just giving some quick updates that I will include slides for. And now I am turning it over to Ellen Frank Miller, who will give us an update on our career pathway mapping project.
Terrific. All right, let me bring up my slides so we can just do a quick review here. I love how every time I share, it covers the screen share button on PowerPoint. There we go. Anyway, so thank you all for having me. I'm really excited to tell you where we are at so far with the project. So just a quick review. As you know, we're looking at existing career pathways with the participating 5 hospital systems. And we are trying to understand, what do they look like today? To what extent are people moving along career pathways? And as April said, we're focusing on 3 key patient-facing jobs. And the first step of our work was to get the perspective of the employer. So looking at some administrative data, which I'm going to give you an update on in just a few minutes, interviews with senior leadership, HR leadership, and then also wanting to talk to some frontline supervisors, which is, as you can imagine, under today's circumstances, quite challenging, but we were able to get to some, and the purpose of getting the employer perspective was really to allow us to design a survey that we could do with employees in these 3 jobs across these 5 hospital systems to really try to get their perspective. And, you know, a little bit of hypothesis testing. You know, we have the perspective of employers, we validate that or challenge that against the perspective of employees, and that allows us to analyze the gap, and that's where opportunity really lives. So when we produce those survey results, each hospital system will get their own report for their employees, and then we will be creating an aggregated report to share with the full collaborative that gives you the complete picture. And then, of course, the career pathway maps will be informed by all of these findings. So we have just wrapped up the employer perspective stage and are now working on survey design. So as you can see, our original timeline had us doing this, right now, and we're just a little bit behind because we're still finishing that detailed analysis of interviews, but we're feeling really good about how we're progressing here. So this, as I mentioned, is an update of the administrative data that we received from the hospital systems here. And so you can see we looked at people's job status, benefits, eligibility, wages, and turnover. And there are just a couple of things I wanted to call out here for you. You know, we focus very much on wages. We know that's a key driver of turnover rates. At the same time, what we know from the research is that once people reach what I kind of think of as a basement level, you know, a floor level of wages where they are able to sustain themselves, their families, and they're, you know, kind of meeting their basic needs, wages tend to drop out of the first position when you ask employees about what are the key elements of a high quality job. So the closer that we move folks along that pathway to the place where wages are meeting their basic needs, the more that other factors are going to matter a lot. An interesting sort of factor that came up here I thought was really worth calling out is that the lowest turnover rate are for the patient service representatives, and they do not have the highest wage rate. That goes to the medical assistants. At the same time, there's strong connection there between the highest turnover rate and the lowest wages. But I just thought this was worth bringing up. I think it drives home that point a bit, and we're going to see in a moment some of the ideas we have about what it might be about that PSR role that seems to be, you know, a little bit more appealing to a subset of workers. So you'll notice in the upper left-hand corner in bright yellow, please take note, these results are from 2 hospital systems. We were able to conduct 12 interviews with frontline supervisors. So it's very important that we do not overgeneralize these findings. And again, the purpose of these surveys is to inform, these interviews is to inform the survey. So, you know, for example, let's say we wanted to ask employees what barriers they experience in career advancement along pathways. We need to know answers, right, to that question. You know, which of the following are barriers to your advancement? We're kind of starting from nothing before these interviews. Well, now we have some ideas of what items can we ask them about. And one of the analyses that I'm most interested in and that we'll really be keeping an eye on is when we give them a set of options And then we'll have an option at the end that says none of the above or something else. We're really going to watch that, because that will tell us the extent to which, we really get what the challenges and barriers are, which means we really know where the opportunity areas are for improvement. If that other or none of the above is high, that is an indicator to us that we need more information to really understand employees' perspectives, to ensure that whatever it is that we design will meet their needs and therefore be used and therefore help us meet our goals. So there were several themes that came out of these 12 interviews with frontline supervisors. We wanted to understand, what did they think was facilitating advancement? And as you can see here, networks, personal relationships, having your manager advocate for you, that was a really key factor. And I think most of us can recognize this in our own lives, in our own careers. When you have someone who says, a manager who says, hey, you know what, I think you'd be great for this role, that can be very helpful, because you might not even know that role was available to you. We did hear about apprenticeship and other kinds of leadership programs, as well as giving folks the ability to advance their education while remaining in their jobs. So working schedules around classes to allow people to attend. And then, just as I mentioned before, just generally communicating opportunities so that employees are aware that they have options and that they can remain with the organization and progress. Another theme we wanted to understand was, what were opportunities that existed today, some pathways. So in some cases, there were actual tiers within a particular position. So for example, you could be a medical assistant, become a lead medical assistant, which involves a little more responsibility, a little increase in pay. Perhaps then you could move into a supervisory role where you are managing a group of medical assistants. Others had more skills-based tiers. So think about like CNA 1, CNA 2, CNA 3, and that's based on the person being able to acquire certain skills that allow them to contribute in different ways within their work environment and made them a more flexible resource for the team. Interestingly, we found that when we think about advancement opportunities, we're certainly thinking about what I just described as pathways, but people view advancement also in terms of their wages. Do I have the opportunity for wage growth? And very interestingly, one of the things that came out during the pandemic was that remote work was essentially a way for people to have wage growth. All of those costs that you associate with, for example, lower commuting, that is essentially then not coming out of people's pockets. It's effectively a wage increase. Some people said, well, I think they're paying less for childcare. Now, that may be true that people have their children around during work, but something that I think we're going to hear also is just that we know that sometimes transportation, public transit, is a little unreliable. We were just talking about this on my team about, like, I'm waiting for the bus and there's no bus. Well, if you're late picking your child up at daycare, you incur a fee. So all of those types of things where you're, let's say, closer to your daycare center, you're not incurring fees, that essentially bumps your wage. We also wanted to know about barriers that managers perceived their employees had for advancement. Degree requirements did come up, particularly for folks who were moving into or wanted to advance along a management pathway. So in that case, when you think about advancement with degrees, for example, into nursing, those degrees are required because they confer the kinds of clinical skills that one needs to do that job. But a supervisor who, for example, has many years of experience in managing a group can tap out because they don't have a bachelor's degree. So they couldn't, for example, advance to a practice manager. Well, do they have the skills to do that job? In this case, folks were saying, yeah, I've seen this happen. They absolutely have the skills, but they don't have the degrees, so they can't be promoted. So that seems to me like an opportunity area. Education is certainly a barrier in some cases. And as we know, finances are a difficult part of that. That can, and there are some interesting things going on. Some folks are moving from tuition reimbursement to paying tuition in advance so that people don't have that double hit of, I have to be able to pay for my education before I can actually then get reimbursed for it. Another thing that came up is sometimes jobs are posted externally And even if they're posted internally, it may be for a short period of time before they're posted externally. The word hasn't gotten out, so folks who are internal and good candidates may not get to it quickly enough. And then also in various different departments, like for example, in specialty practices, they might have higher budgets and be able to, for example, create some of those tiered pathways: medical assistant 1, medical assistant 2, medical assistant 3. But in other areas of the organization, there might not be the same budget available to create those pathways. So, some of that certainly has to do with, how do we treat different parts of the organization as cost centers? Let's see. So then we wanted folks to give us just their observations on mobility and what they had seen. This is going back to my earlier remark. Folks were interested in these clinical roles moving into the PSR role. Sometimes they were looking to gain operational experience so they could broaden their opportunities to move within the organization. Sometimes they really wanted to get out of those physically demanding, emotionally demanding, tough jobs and move from a clinical role, but stay within the hospital. They liked healthcare, but they just really had, burnt out on some of the clinical challenges. The PSRs, on the other hand, seem to want to move into more administrative roles within, sometimes within customer service, or just look for ways that they could grow their skills and their pay, and not necessarily moving over to the clinical side. So there's sort of that indication of kind of a single direction flow at the moment. But again, remember, there's only 2 hospital systems. And then this idea with tiers that are, or levels that are based on skill acquisition, seem to be valued, and employees have motivation to like, well, how can I get those skills or learn that procedure so I can, move to that next, CNA 2 and get the pay bump associated with it. And then we wanted folks' ideas. How can we improve career pathways? There was definitely some talk about, like, if we train them really well up front, that will make a big difference. That's the first step on the career pathway. Mentorship, creating those job tiers that we mentioned, and also creating that flexibility in job requirements. So those all. And then we asked folks about reasons for retention as well as reasons for turnover. And part of what we were trying to do here is give ourselves the opportunity to do some hypothesis testing when we do the survey. So here's what supervisors think are the reasons people are staying. Well, now let's ask employees, why are you staying? And again, looking for those gaps is where we can find opportunities. So we did hear, oh, people are just complacent, they're comfortable in their role, maybe they don't know what other options are, but that really is a very much like people don't want to advance. So that'll be interesting to test with employees. Work cultures, when they were good, people just liked their team and wanted to stay. And others said that, well, they were trying to get a foot in the door, and they gave the example of, folks who came in as a CNA with an interest in pursuing nursing, and this was their way to kind of start down that career path. And then reasons for turnover, no surprise, low wages and lack of opportunity to grow their wages within a role or in a different role. And then the competition, where they could get a better, get a pay bump by moving to a different institution. Work-life balance was a really big challenge that came up. And one of the things we're interested in asking employees about is the ways in which scheduling practices may play a role. I mentioned commuting before, et cetera, but where is work-life balance actually a challenge from an employee's perspective? And if so, what's behind that? Because the what's behind that, again, is an opportunity area. And then the sense that there were a lack of growth opportunities. So that's, of course, why we're here today. So with that, I will stop sharing and see if I can answer any questions.
Thank you, Ellen. I know that was a ton of information at once. We will be sending out these slides, and luckily I caught the record button before that started, so also the recording. Anyone have questions for Ellen?
I had a quick question. Ellen, in any of the interviews, did the supervisor sort of, were there any questions in terms of senior leadership perceptions or sort of understanding of the dynamics at play? I'm just trying to think if there were anything in terms of like if there was anything in terms of a trickle down of understanding of dynamics and possible solutions to what you're seeing.
Yeah, and again, I'll emphasize it was just 2 hospital systems that didn't really come up. But I wonder when I say that whether, our goal was to talk to folks who were really on the front line, who had direct reports, who were, MAs or CNAs or PSRs. And I just wonder, given their position within the organization, whether they might not know all the way up the chain. So, for example, maybe they had a really supportive practice manager. If I had asked the practice manager, maybe they would have told me a different story about levels above them. So it really didn't come up. But that's an interesting question I'd like to hold on to for the employee survey, because I think that perception, we know from the research base that when people perceive that the organization, supports them, has their back, this is a company I can count on, that improves retention. So we'll definitely be asking questions about perceived organizational support. And again, that can, point to opportunity areas, because messaging in general is a way to drive perceived support. So the survey in and of itself has the opportunity to be an intervention to increase perceptions of organizational support. What we also know from the research is that it presents a risk. So if you conduct a survey and you never act on it, it actually hurts you. If you conduct a survey and you act on it, but you don't communicate it to employees, that can also hurt you. Maybe word of mouth gets out, but if you haven't told folks you've done stuff, they might think you didn't. But if you conduct a survey and then you follow up and communicate, even if the message is, we heard you about your top 5 priorities, numbers 1, 2, and 3, we can't do those. We're working on a plan for how we can meet that. But numbers 4 and 5, here's what we're going to do to try to make that better. Even when you have to give a message like that, the fact that you've given the message, the research suggests tends to increase perceived organizational support. So really, the survey is really exciting, and we definitely want to get at that question.
Thank you.
Tara?
Hi, Ellen. Hi, April. I had a quick question. Is there plans to expand the survey to other hospital or organizational systems? And also, when will the final analysis or the data be completed?
I will let April take the first question.
Sure.
The second question, that's really going to depend on how the fielding of the survey goes. We have 5 hospital systems. We have to target 3 particular jobs within each hospital system, which can be challenging, particularly when you think about we'll email a link. How often do our CNAs check email? So the fielding could potentially extend this, but we anticipate that we'll be able to get the fielding going, and by, I hope, mid-October. We generally leave surveys open from anywhere from 2 to 3 weeks, and then we start our analysis. We believe, come on, everybody, this is going to be exciting. If we get a large enough sample, we should be able to do some of that hypothesis testing that I mentioned, which involves more advanced statistical methods and gives us a lot of really rich information. So that analysis will take some time, and I'm not going to put my stake in the ground, but let's just say the holidays tend to slow everybody down. But that is my hope, and I'll let April answer the first part of your question.
Yeah, so I think we had wanted to finish it this year, but it'll certainly be sometime early next year. Just, for the purpose of doing things sequentially with some, fantastic research methods. And we will not at this point be adding any additional hospital systems. We spent several months building this project and getting partners on board. I wanted a minimum of 3 employer hospital systems, and we have 5, so I'm very happy with that. I think there is, a diversity within those 5 systems. Eileen?
So I was just curious, Ellen, in regards to the job tiering. I mean, what, and I don't know if you know this, but what would be the significant differences between an MA1 versus an MA2 or 3? And has it been tested within any of the 2 hospitals that you talked to? Because I think it offers the opportunity for the perception of growth, but it also gets really tricky in the sense of really differentiating the roles to be able to provide a different grading and provide the opportunity for more skill training and development. So I'm just curious if there was any conversation around that. And then I was also wondering, I have a second question, so if you want to answer that one first.
let me do that so my poor brain doesn't get lost. So we didn't do a deep dive into kind of how those tiers were designed or how the operationalization originally happened. What we do know is that the main objective of creating the tiers was to give people the opportunity to advance their wages. So someone who had been in MA1, gotten experience, they could be moved into MA2 to get a wage bump. So that was really primary. I think that, again, part of the driver there is that when people have very low wages, their top priority is to increase wages. So skill growth, while important and obviously must be associated with that wage increase, not necessarily the biggest emphasis from what we could tell. But again, it's a limited number of interviews.
Yeah, no, it makes sense. And then my other question was there any sense or idea that you may have gleaned when talking with more of the supervisors for these type of roles of how encouraging are they to promote and get their people into other positions or promote other opportunities? And not because maybe they don't know, but because maintaining a team that is constantly turning and then having, trying to get your key top players into other roles is a challenge that sometimes culturally leaders don't want to do, especially at a supervisor or even manager level. So I was just curious if there was any gleam on that, because I don't agree with it, but I do think it is a barrier in these types of roles.
Yeah, I really agree with what you're saying. And I think that when we have different labor market conditions, we see different behaviors, right? If managers have confidence that they can backfill, or potentially that people are moving around within the organization with some frequency, then they're a little more willing to help advance their people because they know that maybe they'll come back to me in a supervisory role later. So tight labor markets make that tougher. I feel like we didn't get any sort of specific about that dynamic, but definitely one of the things that we kept hearing was there's nowhere for them to go. I can't help them move. There isn't another job. In some cases with PSRs, it was like, this is it. In other cases, like, oh yeah, there are lots of opportunities that they have to network and et cetera. But that sense that there aren't enough advancement opportunities sort of made it a moot point. Now, whether that's true or not is another question.
Well, I think it's, we see what we want to see sometimes, and how hard are we going to work to help that environment? It's just complicated, right? It's just not as easy as we'd like it to be. So thank you. I appreciate that.
That's always music to a researcher's ears. It's complicated. People want a simple answer, and we always are like, sorry, it's complicated. But that's how we solve problems, right? We take the complicated stuff, we do research, we pull it apart, and we find the opportunity.
Yeah, absolutely. Absolutely.
Well, thank you, Ellen, for sharing the update. I'm so excited to keep going with that research, especially to move into the employee survey portion. I like how well it's aligning with our the timing with our Good Jobs Challenge money and how we're investing that. So thank you, Ellen. With that, I want to start with our next agenda item, which is an update from Jesse Lava, who is the Special Assistant to the Director at the Illinois Department of Healthcare and Family Services. And his colleague spoke at our last quarterly meeting to introduce the Healthcare Workforce Initiative, a significant state investment. I know many of you have probably spoken with Jesse already. He's been making his rounds, but with that, I'll hand it off to Jesse for an update.
Hey, thanks, April. Yeah, hi, I'm Jesse. I'm at HFS. We're the state Medicaid agency, and now we are entering into the workforce development space in a way that we haven't before. We have a pot of about $180 million that's in this year's budget. We're expecting about 200 million in next year's budget. So let's just say 380-ish that we'll have as one-time funding that we can spread out for a few years. I've been soliciting ideas from you guys, talked with many of you already. And today I just want to share some of the suggestions that you guys have given me in case it spurs more proposals on your part, including ones for collaboration. And I would like to know if you think some of these are really bad ideas, because everybody who gave me the ideas thinks they're very good ideas. The other people who think they're bad ideas didn't mention them. So please feel free to let me know that kind of stuff as well. I am not going to do this as a PowerPoint because it's not yet ready to be shared in written form. So I'll just explain it and you guys can ask whatever questions you'd like. Ellen covered a lot of this ground already, so she kind of stole my thunder in a lot of this, so I'll just go through as quickly as I can. But the framing I'll give is that HFS always aims to give particular support to the Medicaid population. We call them Medicaid customers, and we always hope to make investments that have sustainable and systemic impact, even when it's one-time funding. So to the extent there are proposals for us to provide startup funding for initiatives that no other player is positioned to catalyze or to coordinate, all the better. Okay, so in terms of what you guys have been telling me, in terms of which positions are a pain points, when I've asked that, the answer, of course, is a list a mile long. It would be faster for you guys to list the positions that are not a pain point. Ellen mentioned, CNA, PCT, MA, I'll add RN to that. There are obviously so many more you guys have mentioned, every kind of entry-level tech, respiratory therapists, every kind of mental health clinician, the whole bit. And a critical issue for us as a potential funder is that the bottlenecks are different. Sometimes there are too few trainers, like with nurses, and sometimes there are too few applicants, like with some of the sort of niche tech roles. So the solutions may have to be different, and we're trying to figure out where we'll get the best ROI. And so that's where I would like to continue probing and get input from all of you guys. The actual meat of the proposals. So first bucket, I'll just call recruitment, and this is pre-education. Marketing would go in this budget. So a lot of folks have talked about promoting these niche roles that are beyond doctor and nurse in high schools and employment support offices. Some people have talked about enlisting healthcare professionals to be the ambassadors in their own communities to create a model for entering the field. There's also been talk of creating some online career tools to help people navigate the field and figure out what might be a good fit for them. Once we get to the career development stage, there's the idea for community workforce specialists, a sort of a position to be created that recruits people from high schools and goes all the way towards supporting onboarding. So it's not just the marketing piece and then goodbye, it's all the way through, sort of along the pathway themselves. It's also paid internships and shadowing as is already happening, and creation of pipelines from the schools and the community organizations to the healthcare systems directly. And the organizations ideally would be in the same community as the facility, and there'd be career assessments and mentoring when possible. All right, the next bucket is the education and training stuff. And Ellen went over a lot of this. As she said, there's a push to move from a loan repayment model to more of a scholarship model with stipends and wraparounds to foster equity, grow the potential workforce, et cetera. There are also proposals to cover certification fees and exams. So like for phlebotomy, for instance. But as you all know, we have a flight risk problem already. Healthcare workers leaving to go to Amazon to make $1 or $2 more per hour is a refrain that I was hearing from a lot of you guys. So an open question is how we ensure a strong ROI when we cover everything up front. It is absolutely more equitable, absolutely grows the potential workforce. How do we ensure a strong ROI? I would love to help figure this out with all of you. This leads to the question of career ladders and pathways to make healthcare a real career, as Ellen was talking about. So there's funding partnerships with colleges to ensure direct pathway from a degree to a job. Don't leave students on their own. Ensure the school is near the employer when possible. Give them a navigator immediately so they have an easy understanding of the system they're in and how they can rise. And this isn't necessarily the same thing as a navigator, a career coach or a mentor to both ensure people get the lay of the land and provide that tangible support to thrive. In terms of retention, career growth, the various types of pathways, you guys talked through some of them, but there's clinical to management as one route. There's clinical to trainer, and the challenge is sometimes there's less money for that, which obviously should not be the case. And then there's lower position to a higher one, and those are some of the more commonly invoked pathways, like going from a patient safety monitor to CNA to LPN or something, or even environmental services up to phlebotomist up to MA. And the challenge with this one of the many challenges, would be ensuring sort of a reasonable time frame that people are telling me, establishing a reasonable time frame so people can move through the pathway quick enough and get adequate wage gains by the end of it, and with stackable credentials to then continue advancing their career at the end of it. So it wasn't a dead end, it was actually, it was a door. In terms of the routes that these pathways could go through, the community colleges are obviously a cornerstone, and everyone agrees they should remain that way. Another option, though, for trainings to be tailored to a particular institution or kind of institution would be for us to support pathways that are fully internal, where the schooling and job placement are all done in one place, or having new training institutes that serve certain kinds of healthcare systems. So for instance, one that's specific to FQHCs and provide the kind of training that they would need. So it'd be a direct pipeline from that kind of institution to the FQHCs in those settings. Now, everyone I talked with was concerned about the Amazon effect, like I said, of workers leaving not only their current institution, but the industry altogether. That said, the solutions I heard were mainly about keeping staff at their current workplace, which I totally understand. That is what people are thinking about when they work somewhere. But from a system-wide perspective, we'd want to be thinking about how to keep people from staying in healthcare. It's a lot worse for them to go to Amazon than to go from, Rush to UFC, for instance. So an alternative idea was to create pathway programs across healthcare systems, or establishing pathway reciprocity, so that one healthcare system will honor the path that a worker took at another healthcare system. And if new recruits can see the options at different hospitals or clinics, they might actually find the exact culture and job opening that's right for them, and therefore stay in healthcare. Provided, of course, that if we had such a cross-pollinating initiative, that we built carefully, given the challenges of collaboration. I also heard a desire for new educational programs, of course, new nursing programs, because there are so few trainers as it is. A specific one was a new lab program in Chicago to support lab techs and so on, since the closest is in Elgin. New incentives for community health worker trainings. These will soon be Medicaid reimbursable and thus potentially sustainable once this gets off the ground, hopefully in a year or so. And in any of these cases, there could conceivably be an endowment that we would set up to fund a set number of trainer positions. And this could achieve impact on an ongoing basis, which is one of our goals. However, there is a question of where to find these trainers. There were proposals to recruit from the ranks of those who'd otherwise retire or leave the profession. Maybe this could be a way to avoid burnouts while staying in the field, but the money would need to be adequate, and other things would have to be in place as well, that again, I look forward to working with all you guys on. Clinical education was a particular concern for some community colleges. Said they'd like to accept more students, but the clinical education piece is a bottleneck. So if students can't get trained in the clinic, there's no point accepting them to a degree or certification program that requires a clinical component. Apprenticeship model is another thing. And I know some of you guys have talked about doing that, and others have thought we probably couldn't go there, but that's a very promising thing that a lot of folks have raised, apprenticeship models. Finally, there's the let a million flowers bloom approach. There's so many ways to approach workforce development. So the idea is that we could fund new collaboratives that people choose of their own, hospitals, FQHCs, schools, community organizations, that make their own proposals to satisfy their needs and then submit them. That is what we're doing with healthcare transformation collaborative grants that is already happening. I do want to take this opportunity to say, though, we don't have any grants right now. We are not necessarily doing grants. We don't know the exact route that we're going to take. This is all just a way of spitting back to everybody some of what's been said to me. I want to get through this as fast as possible. I know I'm taking a while. In terms of securing, retaining, and supporting staff beyond education, there is this question of compensation that Ellen was raising. Whether they're wage supplements, that's one possibility. Staff bonuses that are provided incrementally to help people stay, or target them to safety net services, since I know this isn't for most of you, but a lot of safety net places are concerned about losing their workers to bigger institutions. So maybe target the bonuses there, provide wraparound supports such as transportation and so on, and potentially peg compensation increases to completing coursework. Then there's some well-being initiatives proposed, like a virtual support hub for nurses, more mental health for acute caregivers, shared governance, where there'd be more nurse representation in leadership, and then enhanced communication and websites to show opportunities to current employees to keep them engaged. Final bucket, which would be capacity building beyond what I've already said. So there's a proposal for a needs assessment that would be comprehensive, statewide, before we throw darts, that we should really have a comprehensive look at the lay of the land. It could include a poll of current and potential healthcare workers. I know we're already well on the way with stuff like what you're doing. There's also capital outlays. I was actually not hearing as much about that as I expected to, but training facilities and lab space potentially shared by multiple providers, or career planning and placement center was one proposal that I heard. Rural hub, this is not for Chicago, but rural hubs for existing schools. And then administration. A lot of folks are saying if we don't have a workforce lead or a workforce team to really take this on at your institution, it's not going to happen. So hiring that workforce staff or consultants would be important. And then potentially creating learning collaboratives and information exchange opportunities would be helpful too. Last couple things. Technology, telehealth was mentioned. Creation of a remote patient monitoring program to reduce the workload of entry-level PCTs in acute care so they're freed up to do other things. For data, there's a notion of making data systems more accessible, like licensure data, all payer claims databases that people could access and use for forecasting and so on. Any kind of system-wide initiative to assess the supply and demand of healthcare jobs to help with that kind of forecasting. And then finally, curriculum development. There's the notion that maybe we should develop curriculum that's specific to certain career pathways. So like the pathway from CHW, or from community health worker to radiation tech to RN gets its own curriculum and so on. So I will leave it there, and I would love to take any questions or hear any thoughts.
Thank you, Jesse. That is so much. And I appreciate the level of care that you're putting into this research and really making your rounds. And thank you for also coming back to us and telling us what you're hearing. I know that was a ton. I put a question in the chat for
everyone. It was about a third of it, by the way. A lot of deletions had to happen, but yes, go ahead.
I put a question in the chat. If everyone could just sort of share, what ideas really, sparked your interest and you thought, oh yeah, that's something really great that we need, that would be impactful. I'd love to have you just share that in the chat. But also, do we have any questions for Jesse? Or comments that you want to share with the whole group?
Jesse.
Go ahead, Eileen.
Okay. Hi, Eileen Boyle, and thank you for being patient with me. I know we had a brief conversation and we're working on getting another one scheduled. I'm just curious, did you say the timeline for this? Because I know.
I did not.
Okay. Is there you're in discovery clearly. I'm slowing that one of the, I don't know, I'm sure there's others hopefully with me that might be slowing this down in terms of that. But what is the tentative timeline to at least finish the discovery and possibly get into action what you're trying to do? And do you have a sense?
I can't, I have to pull the government here and not give any kind of, I can neither, whatever, there actually is none. Added benefit of being true, as Henry Kissinger used to say, there's no timeline. And the reason for that is we want to make sure we do it right. And we aren't going to say that come hell or high water, regardless of idea generation, we're just going to proceed right now. We want to do this as well as possible.
Thank you. I appreciate that.
We're getting some answers in the chat. Rukia is excited about apprenticeships. Dina is excited about mentoring and career training. Levi in high school career pathways. Does anyone want in training facilities? Does anyone want to jump in verbally? We do have a few more minutes on this if we'd like to ask Jesse questions, share more thoughts.
I just want to say thank you for that information, Jesse. It's exciting to hear actually everything you're doing, especially here at, I'm with Women Employed, and some of the work that we're doing and trying to work with the healthcare industry. And so all of that sounds so great. And I cannot wait to get more involved with what you're doing. Thank you.
Sure thing.
I would just add, I think, part of what I was noting was that the apprenticeships or some of those, they end up covering, sort of a multitude of those ideas or interventions, right? There is the earn and learn, there's the training, obviously there's the mentoring and the career development, like those, if you create a really robust set of apprenticeships and sort of that infrastructure, that potentially different hospitals or healthcare systems or organizations can access, and or helping organizations build out, you know, an in-house infrastructure that could be really powerful.
So I want to make sure I'm getting this, build an infrastructure for apprenticeships that multiple provider systems can access, or am I misunderstanding?
In a sense, yeah. So I think when I was talking to you, I was like, we need more training facilities in some sense. Like I'm thinking about, you know, the fact that there are not enough clinical hours. And so if there was like a space that, or even in some sense, the facilities, like if there was a space that maybe one or two, you know, organizations are sharing or able to access for training. And if you're thinking about, I don't know, having different instructors or different folks come in, or different folks who are able to come into a space and provide clinical training or observations or whatever, that could be helpful, you know, to the entire field.
Yeah. Okay. And I know everyone wants to be polite, and you should, but if there are, let's say if there are any proposals that you have concerns with, please let me know that too.
So I'll just take you on that cue and poke the bear a little bit. I'm wondering, you know, I like the idea of that you raised of having kind of that career coach and advocate to help a student who graduates through college get into the onboarding side of it. How practical is that though, in the sense of measuring? Because I feel like, you know, you have counselors in your colleges or high schools, and you sometimes have good ones, you sometimes have bad ones. Like the practicality of the true meat and potatoes to help that candidate really, you know, take that training, take the opportunity and build it forward. There's always that, you know, mass, and there's only a percentage that maybe take it, but is it a practical solution, or is it sort of just a twist on something that kind of exists already? I'm not against it at all, because I do think right now societally we need more support to our early careerists and helping them navigate the nature of what our world is, and where there's a disparity between what you're getting when you come out of school versus what you have to do in the work world. So I'm just curious, you know, thoughts on that.
I'm open to others' thoughts.
This is Susan Plattner from North Shore Edward Elmhurst Health. What we're seeing, we have a partnership that we've started with the city of Evanston called Aspire, and it's really connecting with the youth, starting with our rising seniors in high school and recent high school graduates who haven't yet decided if they're going to college, where I see that career workforce development role being really critical. What we're discovering is, even though the high school has a couple of post-secondary education counselors on site, and all colleges have on-site career counselors, the students still are unclear on what kind of financial support they could get if they went to school, because you have to apply and get into the school before the school will tell you, here are all the scholarships, here are all the grants available to you through our organization. So I think there's a need for, before they even get into the post-secondary education, and connecting people who may not have resources at home or through their school to those resources, because I'm seeing a clear disconnect in our community.
Susan, thanks for sharing, because I'm just continuing on that. I'm wondering, well, how long has your program been in place? Because we do have the same sort of in our Magoon Institute, starting at actually middle school, but high school and then on. But where we're seeing the challenges is bringing them back into our environment. So I'm wondering if I don't know how mature your program is, and if you're seeing, to your point, I agree, there's gaps there, but are you seeing any kind of result, or is this more of a community service that in general that we're providing?
So this is we just finished our pilot year of doing summer internships along with job shadowing, with our focus being ages of 16 to 20 years old, and we're expanding to provide a community opportunity for 18 to 30-year-olds of underemployed, unemployed, or career changers, people who are looking at getting into healthcare but aren't really sure. And so we don't have a whole lot of data on how successful bringing back the students. Our biggest success is because of the community partners that already exist within the city of Evanston who have been supporting 18 to 30-year-olds over the last many years and tapping into their clients and working with them. So we're not starting from scratch. But yeah, I mean, it's a really good, that's our next step, really.
Eileen,
Yes.
if I could jump in really quickly at Rush, through our Rush Education and Career Hub, we've had 25 plus years of experience, and we do find that having and we're actually trying to we're adding a career specialist now, but we've had people who serve as sort of like near peer mentors and alumni who've graduated, if you will, who we've tapped to sort of be advisors. But we have found like one of the biggest gaps in the things that help students come back is the fact that you need somebody who understands the course taken sequence, right? And what are the types of experiences students should be having in college, because that's where a lot of like first gen students or folks, they're just not clear. It's like they're just taking classes without having a real sense of, you know, where this will lead and what will bring me the most success, and then pairing that with certain experiences, because they are counselors, but it's like, do they know enough about the healthcare? They may not, right? It's a crapshoot. And then sometimes they're like, the counselors are overburdened and are not able to give the attention and sort of energy that students may need who are really, really unsure about the whole process, where you can have really small things like, certain obstacles sort of really throw students off track versus somebody who can help walk them through those things and sort of navigate that. So having somebody who understands the healthcare environment, even the clinical and non-clinical roles that are possible, and then also able to help them have small jobs. Sometimes it's just keeping them in the environment. So even if they're not working in a clinical, like right now we have a student who he helped out, he graduated high school, he helped out with our internship program, like being around, supporting like the instructors, getting the equipment together, all of that. He enrolled in Malcolm X and then he stopped for a second, but then he was still around our program helping out. And now he's back enrolled in a physical therapy program. So it's like seeing it and being around it and sort of having people help to guide him along the way, I think helps them sort of come back and be more connected and understand what's possible.
Thank you. I appreciate the insight.
This is a great discussion. And I just wanted to add 2 more cents before we have to move on, unfortunately. And that's, we're talking a lot about mentorship of students in high school and college. I know that Advocate Aurora, and I'm not sure if anyone is here from there, has just launched a position where they're supporting folks who are coming into those frontline positions that have the highest turnover. So like housekeeping, environmental services, food service, not necessarily, young adults, people out of high school, but adults that they're recruiting from local communities, knowing that those positions are some of the highest turnover and that folks might have a difficult time navigating those barriers, navigating life barriers just to stay coming to work, and then also want to figure out, what are the next steps here? Knowing that there's a next step beyond that entry-level food service is what keeps someone coming. So that's another type of mentor, navigator, case manager that I think is really interesting that I've heard a lot about. This is a great discussion. Thank you so much, Jesse, for coming. Really appreciate you. I hope you'll keep us up to date. As always, let us know if you need more information, more opportunities to get feedback on your ideas.
Well, please feel free to contact me directly, jesse.lava at illinois.gov. I'm happy to talk with everyone.
Thanks, Jesse. And now let's get on to the Good Jobs Challenge. And you'll see that a lot of our discussions today are building on each other. We're just feeding you all kinds of information about our workforce challenges and deciding what to do about it. So as many of you know, we have just been awarded the Good Jobs Challenge as part of a collaborative grant application. The whole point of this from the Economic Development Administration is to provide access to high quality jobs that include good pay, benefits, and career mobility, all these things we've been talking about. So they're not just putting out money to do pipeline work and get people into entry-level roles. They really care about our ability to move people up a career ladder. Our application, our joint application, was one of 32 awarded out of over 500 applications. Out of those awarded, it's interesting that 29% of the projected jobs will be in healthcare across the country. So there are a lot of other healthcare sector partnerships involved. And I'm excited about that because there will be a community of practice. There will be sector-specific community of practices to facilitate collaboration across regions. So we'll be able to learn more from other healthcare sector partnerships in other locations. And the funding will be released in 3 phases. There's system development, because not all of the sector partnerships currently exist like ours does. The program design, which is essentially designing the training models, and then program implementation, where the majority of the funds are directly towards training dollars. So our application was led by the Chicago Cook Workforce Partnership that manages all of our federal workforce dollars, our WIOA funding. Our award is $18.5 million over 3 years, split between 4 sectors, and I'll show those to you in just a moment. Some of the funding will go towards capacity building. So currently, Chicagoland Healthcare Workforce Collaborative sits under the Chicagoland Workforce Funder Alliance, but now it will move under Health and Medicine Policy Research Group, and they already host the Public Health Workforce Collaborative. So there'll be a greater connection between these 2 tables, and we'll also have more permanent staffing model, be able to gain more admin support for things like marketing and communications, and just grow the model beyond 1 part-time consultant, which it is now. But like I said, the majority of the funds are allocated straight to the training programs. And there are also some other supports put in place with this grant. NEWS, which stands for the Network of Employer-Led Workforce Solutions, will be providing support to all of our sector partnerships. So that's been up and running for over a year now, which I participate with and learn from the other sector partnerships in Chicagoland. So this is a graphic that shows you everyone at the table. We are the main sector partnership for healthcare. IT, P33 is launching a sector partnership for that sector. For manufacturing, they have a longstanding sector partnership called CMISP, led by the Cook County Bureau of Economic Development and OAI. And then another new sector partnership in transportation, distribution, and logistics is being launched with Olive Harvey and YWCA. And then we have several other organizations that are providing some support, such as LISC, Women Employed, and World Business Chicago. So today, what I'd like to do is just start at the very beginning with our program design and talk about which career pathways do we want to build training programs for. So we know with some of these funds, we want to create a ladder. Some of these funds could go towards some pipeline work that is on the table, but we know we need to use some of these funds that bring someone from occupation A up to the next level. So what I'd like to talk about today is what could this occupation be and what could this occupation be, or group of occupations. And to prepare for that, I asked our employer partners here to fill out a survey. I got answers back from 8 of our CHWC employers, and a 9th also gave me some insight. The first question I asked was, what are your 5 top occupations for which you have the largest number of vacancies? So your biggest labor gaps. And not surprisingly, nurse was number 1 for everybody. Whether you called that registered nurse or clinical nurse or staff nurse, the titles varied a little bit, but essentially a nurse whose certification is registered nurse was the number 1 for all systems. The number 2 for almost all systems was the certified nursing assistant, also called patient care technician. There was a lot of diversity in actual title for this particular position. But in asking you about the qualifications, these are essentially certified nursing assistants. So for almost everyone, that was number 2. For one, it was number 3. And then medical assistant showed up on 6 of the 8. 2 of the employers don't actually use medical assistants, but for everyone who does use medical assistants, that showed up in the top 5. But as you see, it's a smaller number of, this is actually me totaling the number of vacancies across these 8 employers. So just across 8 employers, we are currently short almost 3,000 nurses and over 1,000 nursing assistants. Some other ones that showed up, I've listed here. We also had some shortages of LPNs and advanced practice nurses. Different techs and lab positions came up a lot. Respiratory therapists came up a few times, as well as some of the non-clinical roles like security guard, housekeeping, patient service rep. I also asked which of the top 5 roles do you have the highest turnover? It's interesting to note that only a couple of systems could provide that actual data and the turnover rates. Several of you said, either you couldn't provide that or it would take a long time to provide that, which is fine. I'm just noting that. So I just listed some of the occupations that came up from the few systems that gave some insight into that. Nurses actually did show up for a few of you, as well as respiratory therapists, some lab positions, and of course, some of those sort of frontline non-clinical roles as well. So given this, I want to today talk about nursing and a possible progressive pathway in nursing that we could use some of this Good Jobs Challenge money to support. I'm not saying that's exactly what we're going to do. I'm not committing us to that today, but that's where I'd like to start the conversation, given all of this, and given our recent conversations. So very quickly, these are nursing, the hypothetical nursing ladder, starting at the entry level with a certified nursing assistant, also often called patient care technician. That often requires a certificate program that could be as little as 9 weeks. And earns an average of about $32,000. Then the next level up would be a licensed practical nurse or licensed vocational nurse, which also takes a certificate program, which you can do in as little as a year and earns a bit more at $52,700. Then the next tier is registered nurse, which kind of has 2 tiers because there are associates level registered nurses and there are also bachelor's level registered nurses. This average salary in Illinois, according to the Illinois Department of Employment Security, is over $77,000. And then finally, advanced practice registered nurses, which has a few different titles, including nurse practitioner, who have masters or doctorates, and they can earn over 100,000. And I know that I've read and I've heard in conversations more recently that our severe shortage of registered nurses who have a bachelor's means that some of you have been lowering your requirements to accept associate's degree registered nurses. And I know that some of you have been playing around with hiring some more licensed practical nurses, because not all of you, I think, currently do. Any questions about this so far? Okay, I'd like to switch to our activity because I am aware of the time is moving quickly. Not that window. So okay, we are going to use a little tool. If you go to slido.com, and I'm going to put the link in the chat just now, and our event code is #nurse. Let me get this in the chat. Okay, you should be able to click on that link in the chat to participate. We're not using the Q&A, we're using the polls. So I'm gonna launch our first poll here. So knowing that we have such a huge demand for registered nurses, I like to start with this. Like, if we were going to build a pathway program that led into registered nursing, and I know, save your thoughts on that for the moment, but who would be the best suited to upskill into registered nurses? People in which positions? And I know I just showed that, that ladder. We know that there's so many other different people who could become registered nurses, right? We've talked about medical assistants and that being on the nursing pathway. So you can add in that word cloud. You can actually add an answer as many times as you want. So if you have 5 different positions in your head that you think could go into a registered nurse, throw them all in there. Okay, we've got PCTs, CNAs, I'm sure. I make a lot of them, medical assistants, patient service reps, phlebotomists. I like anyone empathetic. Is anyone having a trouble with that, with the tool?
No, it's working for me.
Great. So I'm seeing LPN is getting a lot of hits. Can anyone speak to why an LPN would be the most suited to become an RN?
In my past, when I worked nationally, LPN, it was a very interesting, it was LPN or LVN, depending on what state you're in. And it was very interesting in certain areas. It was actually a program that was going away. Organizations didn't want to invest and people weren't taking that course. Where I am now, we don't hire a lot of LPNs at all. And it prompted me to ask the question why. I'm relatively new with Lurie, so I can ask the question why. But in practical sense, you are highly skilled, you have your associate's degree, and you are very close to that RN. You're coming with experience, you're coming with good, strong education. So to me, that is a very natural, easy move into that RN and more advanced degree nurse that you'd be looking for. And one of the challenges we face is the fact that we need experience. Right, the early careers new grad love coming to our organization. We don't have a challenge attracting them. Schools want to partner with us, so it's fantastic. Where our challenge is that experienced nurse, which is why an LPN would be that really nice next step. We don't call them that. We're just looking for associate's degree nurses. So I think it's that from my perspective, in trying to address your question, that's what I would say.
Mm-hmm. Does anyone else have a comment about the use of LPNs in their system? I'm curious to know who's using them, if anyone is talking about using more of them, if anyone knows why we wouldn't want to be using them.
Hi, April, it's Shonda from Loyola. So we use LPNs in the outpatient setting only at the present time, but have just given our current healthcare market, have been thinking about using them in the inpatient side of things as well, but that has not come to fruition yet.
That's great to know. Thank you, Shonda. Okay, I'm gonna pause this one for now and go to our second poll. So I think you should be able to navigate to the second poll in that same link. So thinking from the other perspective of if you're a CNA or a PCT, what's the next logical position that you can upskill someone into? I think we saw, Ellen shared that CNAs out of the 3 positions that she was looking at had the highest turnover rate. We know that folks are looking for opportunities to advance. We also know that some people are CNAs because they see it as a foot in the door. And nursing is the registered nurse or the LPN, hypothetically, on that ladder makes a lot of sense. But I'm wondering if there are other occupations we should also be thinking about. I'm curious about practice manager or technician roles. Does anyone who's writing that want to share their thinking?
Hi, it's Mary Schmidt from Western Career College. Regarding the practice manager, so in the medical assisting training, you have both the administrative side as well as the clinical side. Some of our students have a preference, more for the administrative side of things, although they're trained in both areas. And so for those individuals, we see them migrating more towards administrative roles as they progress and get more experienced.
That makes sense. Anybody else want to jump in with any of the other ideas that are on here? Sterile processing, which I know is sort of a tech role, medical assistant. Technician roles is really getting a lot, yeah. Okay, well, one thing I want to leave here with today, and this is really helpful, is I want to be able to identify who should be in the room to really talk about a progressive pathway in nursing and get the right group of people together who understand, why you would want to hire LPNs or why you wouldn't want to hire LPNs, where they fit in with current practice or where they don't, what makes the most sense for CNA to move up into. So I'm putting a survey in the chat where that is one of those questions is, does anyone at your institution want to be a part of that conversation, whether you are an employer or a training provider? I want you at the table, and I want the right people at the table. So it might not be you, it might be a colleague who hires nurses or is head of a nursing department. I would love to have them at the table. The second question that's in that survey is, what other pathways should we be looking at? I would love for us to do something with nursing. I also wonder, and I'm just going to bring this up for conversation very quickly. Which of these other occupations as either starting roles or destination roles do we really want to focus on? Does anyone have any thoughts?
Hi, it's Mary with MCC again. I'm very interested in understanding the LPN opportunities in the Chicagoland market. The college is strongly considering developing an LPN program. So that's something that I would love to know a little bit more about. In terms of the technician roles, one of the areas that we see a strong need for throughout the Chicagoland community is surgical technology and sterile processing. It's my understanding that there is rather high turnover in pretty much all surgical roles. So that need is a continuous one. So that's an area that I think is interesting from the perspective of the turnover associated and the need associated, but also, the wage earning opportunity at in this particular role is significantly higher than that of, say, a medical assistant. So I think it could be a great career pathway.
Any thoughts on that from one of our employers?
I agree. We have a lot of challenges in those areas, sterile processing being one. And then finding, the retention element, of course, is there. Medical technology is the other one that we are truly challenged. It's hard. It's really hard to find the right match. Respiratory therapy, there's some specifics in it in terms of the qualifications that make it challenging too. And a lot of the early careers coming out are getting so many offers that it's impossible to compete in some ways. And they also find our environment to be challenging. So I think, your labor shortage in nursing, nurse assistant, medical techs. Yeah, absolutely. And we put a lot of time and effort into it, and we should, and we need to continue there. But there's a few other areas that I would say some investment would be really nice. And I think, what was just stated would be interesting. Respiratory therapy for sure for us, and a few other areas. Laboratory would be interesting too, because we do a lot of clinical trials, and finding lab techs that are interested in working with us, which is different than other organizations. We're not life sciences and pharma, but we're also, have some other opportunities that make it interesting. So I would agree.
I hear about respiratory therapists all the time. I'm curious if anyone has some ideas on, what current occupations could we focus on to upskill them to become respiratory therapists? Is that something we could offer to CNAs or medical assistants that would actually be an increase? Or are there other positions that we could look at to upskill them to become respiratory therapists?
I think one of the challenges you've got with respiratory therapy is that if you can't really increase your capacity for that, because if you don't already have a program, you can't start a new program right now because the accrediting bodies have put a hold on any new groups that they're going to allow to accredit respiratory therapists. So you've got to use your existing programs right now. So that's just something to keep in mind.
Yeah, Paul, I thought there was movement to reverse that rule. I'd be curious to know if you know anything. I'd be curious to connect one-on-one about that.
Yeah, I'll definitely reach out and see if they've had any movement in that direction.
Thank you. Appreciate that. I do hope everyone fills out that survey. The next steps are essentially, I'd like to, get a group of people who could really bring an informed opinion to a conversation about a progressive pathway in nursing. And then also look at all of our other options, probably bring those back to our steering committee for some decision-making. I asked employers to give some information on your current pathway programs, because there might be some things that are working very well that we could invest in replicating. I have some holes in that information, and I'm still waiting on that information from some, but I am going to compile it. So thank you all who've gotten that to me, and we can look at that information to see if there's something we can replicate. I also need to get more information from the Chicago Cook Workforce Partnership, who needs to get information from the Economic Development Administration about the timeline and sequencing. So I hope that we can access our training dollars before the other sector partnerships that have yet to launch in Chicago are actually created. So each sector is sort of on a different timeline, but we're making sure that we can actually get our funding on a different timeline as well. With that, I'm going to turn it over, as promised, to community announcements. Thank you all so much for being here today. Really appreciate all of your insights and being part of this conversation. Does anyone have something they'd like to share with the whole group? Any announcements?
And the only thing that I wanted to say, this is Mary with Midwestern Career College again. The college actually purchased another college located in Kentucky and also in Ohio called Beckfield. And Beckfield focuses on nursing programs, hence my interest in, are there opportunities to perhaps, bring some of those programs to the Chicagoland market? LPN is the one that we're probably the most interested in considering launching in the Chicagoland area. So my interest, of course, would be, would there be support both in terms of the clinical externships that are required for the students, as well as job possibilities if we do roll out a program like that. So did want to share that information. I'll put my email in the chat if anybody wants to connect with me on that. I would definitely welcome that conversation.
Good morning, everyone. This is Rhonda at Malcolm X College. Hope everyone is well. Just want to let you guys know that, we're always interested in identifying opportunities to create programs, particularly in our CE space, right? So I know we talked early on about just being able to offer some credentialing opportunities to upskill some employees. So I know, I'm not sure if our Dean Jameter is online, but there's been some discussion around just creating maybe some micro certification. So, employers that may think that there are a couple of courses or certain things that might help employees to be better in their role or to prepare them to move up, we're always interested and open to just discussing those. So one-on-one. Thank you all so much.
Anyone else have an announcement? Last call. Okay, please take a moment to fill out that survey. Or if you would you can also just email me to talk about the Good Jobs Challenge or anything else we discussed today. If anyone is doing youth pathway programs, we would love to include you in our youth pathways committee. Anything for college students, we'd love to include you in our event on November 10th. And our next quarterly meeting, I believe, is December 6th. Don't quote me on this. I believe it's the 6th, but I'll be sending that out in the email with this recording and the slides, which will come out in the next couple of days. Thanks, everyone. Have a fantastic day.
Thanks.
Thank
Thank you.
Bye.
Bye. Bye all.